Okay, so again, we touched on some of this, but I just wanted to sort of bring up other aspects. So here's a quote. So my father is one of the smartest men I've ever met, but he's complaining about being weak. I keep telling him to stop being so hard on himself, but I also tell him, how can he expect to have energy if he isn't consuming enough? So there's this idea about wanting to sort of soothe your family, your loved one, but at the same time, you want them to do something. And that's can be quite a toxic mix. Monica, do you have any sort of scenarios or thoughts or approaches to that?
Yeah, so this comes up quite a bit with, it can be related to weakness, it can be related to around eating or other sort of goals, but we'll often see patients and their family members or friends, whoever it is that's important in their life, having sort of differing points of view about what's important at the time or ways to achieve specific goals. Often I spend a lot of time with patients and families, and sometimes individually or together, depending on what makes sense for them at the time. If there's a lot of conflict or differing opinions, to understand what the core motivation is. So for families and patients, sometimes it can be the fear that their loved one is not doing well, that they're worried about their cancer treatments and how their disease is progressing. And so it's sort of understanding and acknowledging that that's a real fear, but that maybe there are other strategies to approach, whether it be weakness and sort of trying to get somebody, like you were talking about just now, Eric, pulling them out for a walk when they really don't want to. And then looking as well with the patient to see what's going on with them and why is it that they don't want to do it? Is it that they're having some other symptom related issue that we need to intervene on? Or is it a fear that they have, that they're afraid that if they go out, like we have some patients who are feeling quite weak. And so we'll say something like, maybe go for a walk around the block per day, but they're actually quite afraid because they think their capacity is less than what it may be. And what we found in our clinic is when the physiotherapists do the 6-minute walk tests with our patients, they're often quite surprised about how much they can actually do, or their family members may be surprised because they expect that they haven't been doing much and they've been self-limiting potentially. And so it's building up confidence and safety measures and sort of backup things of going for a walk with somebody, or perhaps finding a negotiation strategy between what the patient wants and the family members want to find a way through those complex situations.
Okay. Christina, I think you've probably got a whole bunch of examples of this playing out. So what do you say to that sort of situation?
Yeah, I think I come across this pretty much weekly, the struggle between caregivers really wanting to do the best that they can in providing nourishment to their loved one, and preparing meals and trying even new recipes and that, and this conflict and difficulty that exists when the patient just can't eat it, or doesn't enjoy it, or can only have a bite or two. So it can be distressing to the caregiver, but it also causes distress to the patient of feeling the pressure of I can't eat this meal. So often I just try to find ways with them of opening the dialogue really about what the patient wants to eat. Sometimes it can be a very simple question like, is there anything that you would be willing to try, and starting from there. So definitely this is something that happens frequently. And I think it's just a question of realizing that there is frustration on both sides, for the caregiver preparing the food and putting in that effort, and then also frustration on the patient's end, who may feel pressured to eat, even if they really just can't, and not because they don't want to, but because they have no appetite, or have symptoms that are just making it too difficult for them to tolerate the foods that are prepared. So I work very closely with the patient and caregiver and try to find, sort of as a mediator, a middle ground of ways that to help both sides, really.
Just on that note though, is it your impression that generally you do find a solution, or do you find that that conflict or that different perspective is just there forever, and it's sort of really difficult?
I'd say generally speaking, we do tend to find a middle ground. and find solutions that, because I think sometimes it's simple things like a patient saying, really, I can only have liquids, not because there's any physical difficulty to have solids, but really because they just find it the easiest way to get in nourishment throughout the day. And that, for example, a caregiver, they might find that odd or distressing that they're only drinking, but then it's sort of explaining, well, we're not talking about just water. We can discuss some fluids that are calorie and protein dense that will still help the patient meet their needs. That's one example, but just saying that, yes, usually you can find a middle ground, because the aspects of eating that are distressing to the patient and the caregiver may be very different.
I just may add, oh, sorry. No, I was just gonna add in too, when it's symptom related, Christina and I will, and all of us as a team will work together to sort of see what that barrier is to the person eating well. So if it's nausea and vomiting or a food aversion or something like that, we try first to deal with that symptom related problem, to have access then into how to deal with the actual eating appetite and enjoyment of food.
Sure. Eric, did you have another comment?
I think one thing is just really recognizing how distressing this is for everyone in the house, and being really clear that you're not alone. This is a normal thing. We all want to love on one another, and the way we show our love in many families is by feeding you. And so I have seen extreme examples, as I'm sure my colleagues have, where people pretend to be asleep so that they skip meals, or they weigh in at the doctor's office with, weights in their pockets so that they don't have to have a conversation with their loved one. So it's that fine balance of being present and advocating and kind of having those options available for your loved one, but at the same time, not pushing too hard. And we're all wired differently, and so some of us are a little more pushy. So I think just being aware of it. And then the last piece I think I find helpful is really discussing the difference between starvation and cachexia. And people don't know that. And I think just knowing what cachexia is gives them a label of actually what they're living and experiencing. So even if you fed your loved one nonstop, they may still lose weight because their metabolism is so high given their cancer. So I think it's just kind of framing the whole experience and really letting them know what it is, rather than making them feel like they're alone.